Welcome everyone to our January Tobacco-Free Tuesdays webinar series. As people are joining, we're going to kind of take a few minutes, and if you could put your name in the chat box and also a resolution for this new year that we all kind of start out the new year with. But if you don't do resolutions, maybe put in your word for the year. So what would you like out of this year, your word or resolution? Put that in the chat box as we're kind of welcoming everyone to the webinar.
In honor of our guest today, we'd also love to know if you yourself are a tobacco treatment specialist. If so, add that to your name too, that you are a CTTS or a TTS.
Carrie does goals. Very, very good. And someone put healthy as your word of the year. Word, thought, embrace, change. I like that, Pam. More, Jane, more travel. Jane is our traveler. Take the chance. Rita, I like that. Honesty. I love this. So welcome. If you've just joined us to our January Tobacco-Free Tuesday, first webinar this year so far. And if you're just joining, if you could put maybe a resolution for the year, or if you don't do resolution, put maybe a thought or a word for the year. Eating better. Definitely. Nobody's, I don't think, I haven't seen everything in the chat. Mine would be, my resolution would be exercise, but I have not started that yet. So I'm gonna take some time to think about it. I like that one. Gary, I'm lucky to no longer be a smoker. I like that one a lot. Making more time for fun. My word for the year is peace. Acceptance. All of these are so good. Thank you for putting those in the chat with us. And welcome again, not second guessing my decisions. Excellent. So I'm going to go ahead and get started because we have a pretty full agenda today. Again, welcome to 2023, our very first webinar for January. Believe it or not, the month is almost half, or is actually over half over, January 17th. So we're moving right along. So thank you again for joining us. I would like to, if you've just joined, put your resolution or word for the year in the chat box, where you're from, an organization, your organization, and if you are a tobacco treatment specialist or if your organization employs tobacco treatment specialists. We're very excited to have Marlena Parson with us today. She is a board certified nurse practitioner from the Duke Smoking Cessation Program, and she will be presenting information on what it means to be a tobacco treatment specialist and the pharmacology of nicotine replacement therapy and cessation medication. So we're very excited to hear more about that shortly. I would like to introduce myself. I'm Gina Roberts, the acting program manager for the Virginia Tobacco Control Program. And as you see, and always will see on our screen as well, are the regional coordinators throughout the state. We have Carrie Cannon from the northern region. We have Nicole Mann from the eastern region, Sarah Burkhead from the central region, and Tiffany Eustace from the northwest region. And also I cover the southwest region as well. So we're here for you to call upon us, to work with us, and we'd love to be a part of your team as well. So we are going to, I'm going through my agenda to make sure I'm not missing any pieces. We're going to start off this webinar series on a good foot in January. So we're putting up the opening poll. This is like our tobacco tea question. What are the most common tools you hear people credit with helping them to successfully quit using tobacco products? And you can check all that apply. And you see there are many down there. Counseling, whether it's one-on-one, whether it's quit line or a class, the patch, the gum, the nasal spray, inhalers, lozenges, Chantix, Wellbutrin, vaping, or none. They just quit cold turkey. So which ones are you seeing the most out there with your work? Give you a couple more seconds to kind of check those off. and then we'll see what is being used in Virginia. Okay, so the patch, slightly ahead, counseling, nicotine gum, and Chantix were the top ones that are used. And of course, you know, we do also know that best practice is to use a combo of nicotine replacement therapy. Of course, with the patch, which is long lasting, you can also combine that with the gum or the spray as well. We do have a very interesting fact. Let me see, cold turkey. Let me see how many people put cold turkey. I've got to scroll down. 44% of you say you have heard cold turkey works. And I've got an interest in statistics. Out of 100 people who try cold turkey, only 3 to 5% actually quit with tobacco for over 6 months. So it may work out well to start with, but it doesn't last. So that may not be your best option. And of course, counseling with nicotine replacement therapy is also good as a best practice as well. So thank you for sharing that and what you've heard out in the community. So now I'm going to go ahead and start with our speaker because Marlena, I know you have got some interesting data to show us and some stories to tell us about your work in the community. So Marlena Parson, as I mentioned, is a board certified nurse practitioner specializing in family psychiatry and tobacco treatment. For the past 20 years, she has demonstrated success in assessing and managing clients at all levels of care, including emergency medical, crisis stabilization, and outpatient settings. She, on a typical day, serves as a tobacco treatment specialist, and she conducts detailed diagnostic interviews, collaborates carefully on treatment plans, and helps each client discover their personal motivation and vision toward achieving independence from nicotine. And I loved also, she put in her intro about how you spend your free time. And I'm not sure how you have free time with all of that, but Marlena enjoys baking bread, playing Frisbee with her dog, Sunny, and swimming the 500-meter freestyle with her master swim league. So welcome, and we really appreciate you joining us today, and I am going to turn it over to you.
Thank you so much for the intro, Gina, and thank you for this opportunity to present today. I love being with you all. I'd like to go ahead and share my screen. Let's see here. Are we a go?
Yes, it looks good. Thank you.
Okay, excellent. Well, I'm so glad that we started off with our resolutions. Everybody has beautiful resolutions. I'd like to say that the only place more popular than Planet Fitness in January is my clinic. Everybody is pumped, ready for a new year. It's a new me. And part of my job as a tobacco treatment specialist is taking momentary motivation and extending it and hopefully getting results that are long-term. And so I'd like to share with you more about the science behind what I do, the methods, the interventions, and how I help people realize this a smoke-free future. So this is a blueprint of what I'll be discussing today. I'm going to talk about the stats, the scope of tobacco use, who's still smoking, tobacco-related illness. A lot of you are very aware of this, but it's always nice to review this. Abstinence rates. I'd like to talk about the pharmacology, the medications. That's my main bread and butter. I'd like to talk about behavioral treatment, and then if there's time, hopefully, I'd like to discuss the effective therapeutic alliance. It really is a foundation for an effective long-term quit. It's how I take all of the science and the knowledge that I've gained over the years and apply it in the service of the individual client. And so my goal is that this next attempt might be their last quit attempt. So these are the US stats. Made a lot of progress already. 14.1% of the US population identifies themselves as being smokers, and 68% of those would like to quit. This 14% was closer to 50% a couple generations ago. So there's been a lot of progress made. The mean attempts is 7. And a lot of those, I suspect, are cold turkey attempts. And these are the stats in Virginia, and I find these really, really notable. There are all kinds of stats from different sources, but of course, VDH has the best stats out there. And I really like this study from 2017 because it shows how our targets are hardening. You know, 2/3 of people smoking in Virginia have already quit. And so for those people, they were able to do it without the challenges that perhaps this last third, this 13.9, are experiencing. And people like myself are trying to help those 13.9 join the rest in the 25.9 and being former smokers. It's also really notable that, you know, Virginia, a historical, you know, tobacco producing state, has a, you know, consistently under the national average in terms of current smokers. Most have, you know, former tobacco states, current tobacco states have over the national average. So you're already doing amazing work and making a lot of progress. I just wanted to note that. So who still smokes? We see some important demographics here. Education level has a lot to do with who continues to smoke. GED, high school grads are more likely to smoke. Income level, people with incomes under 35K a year, a much higher rate of smoking. And then throughout my career as a psychiatric provider, I've certainly noticed that people with mental health conditions are more likely to smoke. The prevalence is much higher. So 40% of men with a mental health condition, 34% of women still smoke. And then another notable stat is that the proportion of all cigarettes smoked is mostly, you know, smoked by people with a mental health concern. Carcinogens, you know, these are things that we don't want anywhere near our lungs, right? Arsenic, formaldehyde, nitrosamines, these are things that to take note of are in the cigarette smoke. And 51% of smokers, unfortunately, die from smoking. A lot of people are aware of lung cancer, but, you know, heart disease has surpassed lung cancer as the major cause of death in the United States for smokers. COPD is also in the top 3. We also see stroke, other cancers, and other diagnoses. So Surgeon General's report in 2020 was pretty much an ad for smoking cessation. They had an entire section devoted to smoking cessation and access to smoking cessation nationwide. They also had a separate section about tobacco-related illness. And I really like to use the results of this report to find what really resonates with each client. A lot of them already knew when they started smoking that lung cancer was a risk, but they might not have known about COPD or diabetes or preterm delivery and stillbirth risk, or about the other dozen cancers that can happen when you're smoking. So I like to see, you know, what resonates with each client and share with them the ways that they can reduce their risk by quitting smoking. And I love this table. This table represents the hope I have for each client I work with. So I have clients who present to my clinic and they say, I've been smoking for 40 years, 50 years, it's too late. I don't know if quitting right now would make a difference. You know, my health is already determined. And this table, you know, demonstrates that things can turn around, you know, risks go down. The risk of lung cancer for current smokers, you know, 8.43 relative risk, and it goes down to 3.85 when they go smoke-free. So, you know, this is amazing to know that, you know, we can start working on this today and start reducing your risk today. And that's always a great boost for motivation when they see that it's not too late. We can start working on this and turn things around. So when do people start smoking is a really important question. We notice that the average, you know, the mean age is around 16, so really, really young. And what's notable about that is, you know, particularly between the ages of 12 and 20, where most people start smoking, this is a critical time in brain development. This is where gray matter in the brain is really bulking up and some permanent neural pathways are being developed, particularly pathways that affect impulse control, attention, and reward centers. And so this is the time, this is a delicate time where susceptibility for addiction can become long-term, become permanent. So if I have two clients and they both have a 20-year pack history, I still need to know, when did they start smoking? Not just how many pack years, how much are they currently smoking, but what age were you when you first started smoking? Because people who start smoking in this 12 to 20 year range are likely to have a bigger challenge than somebody who started in their 30s or 40s, no matter how much they're currently smoking today. Smoking abstinence rates. And so, yeah, I mean, Gina already sort of covered this, cold turkey, the self-directed quit attempt is usually a cold turkey attempt, and that's a 4.5% chance that they'll still be abstinent in 6 months. Working with a provider, usually a primary care provider, we call this a pep talk and a patch. And so your provider will say, I'm invested in your wellness. I'd really love to see you quit. I think it can really help with your comorbidities if you quit, and gives them a patch and says, I'll see you in 6 months, or I'll see you in a year. And we notice that there's some benefit of that for sure. So double the rate that with a self-directed quit attempt. And then quit line. Quit line, not always medical professionals, but they do a lot in terms of follow-up. They'll text you every day, they'll text you every week, they'll do phone calls every month. And so that follow-up does give us an 11% abstinence rate after 6 months. So that's notable. And then working with a specialist like myself in programs across the country, we tend to see about a 30% abstinent rate after 6 months. And so we're proud of that. I have to say that in my clinical practice, I see that number is really closer to 40% for my clients who commit to the pathway of medication and enhancing that with therapy, either a group therapy or individual therapy. That number is closer to 40% in what I'm seeing in practice in terms of the 6-month abstinent rate. And so, presenting clients this data is probably not going to be very effective. But what I do tell them, I have some clients, they log in with me, they come in to see me in clinic, and they are just exhausted. They're just, I'm not sure if I have time to do this. I already have a cardiologist and have a pulmonologist. I have an endocrinologist and a pain doctor. I have a rheumatologist. I have a functional medicine doctor. I'm not even sure what that is. I have a dentist and a psychiatrist and a therapist. I have so many providers. I'm not sure if I have time for this. I'm not sure if I need this. And what I like to tell them is that, working closely with me for 3 to 6 months, going smoke-free and starting to see the comorbidities become more manageable, you can start to peel away some of these specialists. If your blood pressure is more stable because you're not smoking, you may not need a cardiologist tinkering with it every 3 to 6 months. They might be referred back to your primary care. Same thing when it comes to blood sugar and A1C. Going smoke-free, a lot of times endocrinologists can refer that back to primary care. We're starting to reconsolidate your care with a central provider, and it's not keeping up with all of these copays and all of these appointments anymore. And so I let people know I'm committed to helping them, see if they can sort of fine-tune things in terms of their care being sort of in the hands of all these different specialists. A lot of them have 5, 6 specialists that they're already working with. And so that really boosts their motivation. And they're just, a lot of times are like, let's do it. Let's go. I'm ready to go, and make some time for you on my schedule. So I'm always really happy to share that with you. So nicotine withdrawal, whenever we're approaching a quit attempt, we're managing 2 main things. We're managing nicotine withdrawal and staying ahead of that. And we're also managing triggers and cues. So nicotine withdrawal is sort of pulling the rug out from underneath the neurotransmitters that help us with our daily functioning. When your dopamine levels plummet, you're really prone to agitation, irritability, feeling down and anhedonic. Low serotonin, much more trouble managing, regulating your emotion, also trouble with sleep at that point. When your norepinephrine bottoms out, you're feeling really unmotivated, foggy, just sluggish, and can't focus. And so The withdrawal can last for 2 to 3 weeks. I'd say the first 72 hours is probably the roughest. Then 2 to 3 weeks is really where a lot of the return to smoking or relapse occurs. Emotional dysregulation can continue for 3 to 6 months. I usually say with a new patient, I ask them how do they feel about a 3 to 6 months of medication, and most are good with that idea. And then we talk about triggers. Smoking, there's nothing like smoking that really becomes intertwined in our daily activities. And so I've got clients who, every time they wake up in the morning, they smoke within 5 minutes, or every time I have a beer, I pair it with smoking. I smoke every time I have a good meal. I smoke anytime I'm stressed. I smoke to celebrate. I smoke at the end of the day as a reward. I worked hard all day. It's time to smoke. I have people who smoke socially. They picked up smoking because their partner smokes, their best friend smokes, their roommate smokes. I also have people, interestingly enough, who are smoking to sort of carve out their own space. I notice this a lot in blended household. I have a couple of patients who smoke because they are trying to signal to people, I want me time. And nobody goes near grandpa when he's smoking a cigar. Grandpa gets his own man cave because he's smoking a cigar and nobody wants to go near him. And so there's all these different, ways that smoking becomes part of your daily life. And I also notice with boredom or lack of activities, a lot of my clients are recent retirees. They were smoking a few cigarettes a day, and now that there's no sort of structure during their day, they're up to a pack a day, and not sure how bad it's going to get. So again, there's all kinds of reasons that people smoke, and I love getting to, why they smoke, how they smoke, where they smoke, because that's really important to understanding them and how to move forward and help. Smoking urges. I like my clients to try an experiment, try to ride the wave. That's one of the first skills that we like to impart with clients. So smoking urges are ephemeral. They're very temporary. It may seem like an eternity, but if you set your egg timer, it's only 3 to 5 minutes and the urge passes. And we describe riding the wave as just sort of acknowledging there's an urge, letting it happen, letting it sort of ebb and flow away, and just riding that wave and just seeing, you didn't have to smoke and it just went away on its own without lighting up at all. And people really like doing this experiment, and they'll do it several times actually to just see, you're right, it was only 3 minutes. It's a great way to sort of change the perspective on things. And so how about going cold turkey? How about not going cold turkey? So there's nothing like going cold turkey to reinforce the dependence. Who wants to, have these intense cravings, irritability? Nobody wants to hang out with me. I can't focus at work. I'm not sleeping. I'm not eating. My nerves are frayed. I'm feeling down. I don't even want to get out of bed. And so there's nothing like this sensation to signal to the smoker, of course I need to smoke, and I have people who come to me saying, I don't smoke because I like it. I don't like it anymore, but I smoke because it's better for my relationships. I work better when I'm smoking. Last time I tried to quit, it was a mess. I almost lost my job. Nobody wanted to hang out. Nobody wanted to spend any time with me. And so I had a client recently who, before I can even introduce myself, he was so excited because he had planned, he had cracked the formula of how he's going to quit this time. And he told me, you know what, I don't have 2 weeks of vacation leave, but I have almost 2 weeks. And I told my boss that I'm not going to come in for 2 weeks. And I told my girlfriend, she's going to move in with her mother for a month so that I can quit, because I know every time I quit, things get so out of hand. And I'm angry all the time, and I can't focus at work. I'm in construction. If I'm not focused, somebody could die. So I've already got that done. So we're good. And I tell them I love the initiative that you're taking. Was that a cold turkey attempt though? Was that doing it with no support? And he's like, well, yeah, I just stopped smoking and it was a disaster. And I tell them, that, what I do is the opposite of going cold turkey. What I espouse and our program espouses is a gradual, intuitive quit based in the science. I want to make sure that your nicotine withdrawal is well managed and things are as comfortable as possible. I really want to empower you to be able to quit without having your support system move 30 minutes away for the next month. I'd like you to be able to save your vacation days for something fun because you earn those days. And so I'm happy to report that this client was able to get on nicotine replacement and augment with an oral medication and has been smoke-free for over a month now. He quit early, he quit the week before Christmas, and nobody had to move. And he was able to not use any of his vacation days because it went a lot smoother this time around. And so we're hoping that he's quitting for keeps, but perhaps even if he does return to smoking for some reason, at least now he's had this really good experience with quitting. And next time he'll won't delay it as much when he decides to embark on another quit. So what actually works? What actually improves outcomes? So these are some things: medications, that's my department, behavioral treatment, both group and individual sessions, and then follow-up. So follow-up from the time that we commit to a plan to reducing cigarettes per day, approaching a quit date, and then beyond the quit date. So sustained release medication. So you might be familiar with a few of these. We were just talking about them. So nicotine patch is a classic, been around since the 70s. It's a full agonist at nicotine receptors. Then we have varenicline, formerly Chantix, and that's both an antagonist and agonist at nicotinic receptors. And then we've got bupropion, also called Wellbutrin or Zyban, and that increases dopamine or norepinephrine. So some immediate release medications. So I call these on-demand nicotine. And so, if you're using a sustained release medication, that's great, but there's still going to be some cravings throughout the day or some cues throughout the day that could still occur. So I love being able to recommend the nicotine gum, lozenge, nasal spray, a little less popular, and then the nicotine inhaler. And some people ask me, I get a lot of questions about the inhaler because people will say, well, isn't that an e-cigarette, or what's the difference between using an inhaler and smoking? And so it's the inhaler, if you've never seen it before, is a small plastic tube that is almost like a kind of like a fake cigarette, and the method of use is to sort of inhale it through it. There's a cartridge that goes in it. You inhale it, puff out your cheeks, and you're absorbing nicotine buccally through the lining of your cheeks, not through your lungs. Where the lungs are a sacred space, we're using through the cheek as a nice way, a safer way to absorb nicotine. So yeah, I love these interventions. A lot of them are over the counter, and this is how we provide relief when urges occur. This is how we replace one ritual with a safer ritual as well. And this is how we substitute routine cigarettes. So, I have smokers who kind of smoke on a schedule, and they've structured their day around when they're going to smoke. And so I often tell people, your first cigarette of the day is probably not going to respond real well to using nicotine gum. You've potentially been in withdrawal for 8 to 10 hours, and the gum is probably not going to cut it. But perhaps your second cigarette for the day, the one after coffee, or the cigarette that you usually have on your way into work while you're commuting and you're not even paying attention to the cigarette, that you could use a lozenge instead, or the gum instead. And there is some there is some expectations of the user with this. When you smoke a cigarette, it lights up your nicotine receptors almost instantaneously. But these immediate release are slower to act than that, and that's part of the reason that they're not as habit forming. It could take about 10 minutes for the nicotine in the gum or lozenge, which is comparable to that, and that's contained in a cigarette, to reach those receptors. And so That's why it's good that we've practiced riding the wave a little bit. That's why it's good to sort of know yourself and your patterns throughout the day so that I smoke every day at noon, no matter what. To pop a piece of gum in your mouth and get that tingle going and park it at 11:50 would be a great idea. And that way, when you go it's 12 noon, you've already got your nicotine. And so these are some of the skills that I like to practice. And this is some of what makes the difference between, a self-directed quit, picking up a pack of gum at the pharmacy and then working with somebody who can sort of, give you the tools and the ideas and the ways to sort of, work this into your routine. So in my work, I have to debunk a lot of rumors and hearsay. I've got to deal with Reddit. I've got to deal with my cousins, uncles, mother-in-law said that this happened. I have to deal with a lot of that. And unfortunately, I also have to deal with the insert on the in the actual patches, which contains some information that really isn't rooted in the science, but can cause a lot of confusion. It states to not use the patch while you're still smoking. And so I have clients who believe the patch doesn't work for them because they will still get urges to smoke on the patch and think that they're not allowed to. They'll take the patch off to smoke and then lose it, or it ends up on the dog, or it ends up, in the garbage by accident. And then, very quickly, it all kind of evaporates and they stop using the patch. But I love to let them know that, nicotine replacement can be safely used while smoking. I let them know if they smoke while they're using the patch, they're more likely to have some nausea and some awareness of heartbeat. And I let them know if you're smoking and you notice that you're feeling your heartbeat more, please put down the cigarette. Don't take off the patch, but please put down the cigarette. Luckily I can usually, at Duke, trend their blood pressure over the past year. And so I can definitely determine that they can afford the 5 to 8 point increase to their systolic that sometimes occurs when they add the patch in while they're still smoking. I provide a lot of education about how to use the patch. If somebody still wants to have a quit day and then start the patch, that's fine, but I do let them know and empower them through information that they can do it in a more intuitive way as well. And then, of course, we've found that using the patch after a heart attack or stroke is definitely preferable to nicotine withdrawal. It's a second-line intervention after behavioral treatment for those who are pregnancy and breastfeeding. And this is all about harm reduction. And so, so the patch can have a role for people who are pregnant. Who are wanting to be smoke-free during their pregnancy, and then it's effective in adolescence as well. Okay, so next we have bupropion, also called Wellbutrin or Zyban. It's an antidepressant. It's still widely used for smoking cessation. This is great for preventing acute nicotine withdrawal. It prevents that dopamine and norepinephrine from bottoming out. And it's a great choice for smokers with mild to moderate depression. I love using it this time of year because people who are susceptible to seasonal affective disorder tend to get a real boost from taking bupropion this time of year. It's the get you out of bed medication. And so it really does help boost your energy and your motivation. We also kind of use it sometimes as an adjuvant for people who have ADHD. And some people are smoking because it helps them focus. And so it's great to know that I have this in the toolbox as something that I can offer to patients. It also really helps with post-quit weight gain. I had a client in the fall who gained, a lot of weight. She was able to quit on the patch and gum, but turned around and gained 40 pounds the first time around 3 years ago. 2 years ago, she gained 30 pounds. She really wanted to quit. And so we went ahead with the patch that's always worked so well for her. And then we added in the bupropion. And this time around, she only gained 5 pounds and she's already lost that. That was very easy for her to lose. So I love the fact that bupropion can help us remove that barrier of the worry of weight gain for some folks. There are some contraindications with this. This is a medication that really helps decrease the comfort and soothing sensation of taking anything from your hand and putting it to your mouth. So it's great for fingernail biting. And there are people who compulsively eat their hair. It's great for snacking. And of course, it's great for smoking as well. And it's great for what we call self-directed repetitive behaviors. And so for people who are already struggling with an eating disorder, this is not a good fit. This could potentially dangerously suppress their appetite. This is not a medication that we recommend in people with a history of seizure disorder that is not well managed. It does tend to lower the seizure threshold a bit more, about 1.5% more likely to have a seizure than on other antidepressants. And so that's statistically significant for us. And I would certainly confer with a neurologist if that was somebody who had a seizure disorder, but we can usually avoid using that. I don't love using it with people who have anxiety that's not well managed. For some people, the sort of the boost of energy that occurs when taking bupropion presents as sort of a restlessness, and that unrest can lead to a lower threshold for having a panic attack. And so I don't tend to prescribe it to people with poorly controlled anxiety. Similarly, people who have insomnia, particularly delayed sleep onset, don't tend to have the best results with bupropion, because if it's taking you over an hour to fall asleep already, bupropion will make sure that it's 2 hours or 3 hours to fall asleep, and most people can't afford to do that. I don't love this medication in people with PTSD because oftentimes they are prone to hyperstoroidal and hypervigilant states, and that extra norepinephrine can really intensify those states. So there's a lot of highlights here, and then there's a lot of cautions as well, as with all medication. And then varenicline, formerly Chantix. So this is both an agonist and antagonist at the nicotine receptor. It was designed specifically to help smokers quit, and has some impact on withdrawal, and that's the agonist part of it. And then it also impacts reward. So it's also blocking some of the nicotine receptors. So when you go to smoke, it's not as rewarding. People report to me that they go to smoke and it doesn't smell the same, it doesn't taste the same, and we're breaking up the behavior. So it's not as familiar and it's not as comforting. People tell me they smoke and it tastes like they bummed somebody's cheap cigarettes. It doesn't, and they taste like ash and they smell like an ashtray, and so that's a real highlight of varenicline. It really impacts the cue response too. I have to say the most famous quote among my clients who start varenicline is, "I forgot to smoke. I just woke up one day and I forgot to smoke. I don't even know what day it was. I forgot to smoke. I don't even know where my lighter is. How did this happen? You just took away all my urges. I don't have it anymore." And so that is why, despite hiccups along the way, varenicline continues to be a wonderful intervention to have in the toolbox. So considerations with varenicline, about 40% of people taking it will get nausea. I can make that more like a 10% risk if, a client takes it with their first full meal of the day. And I say that a meal that's more than like a handful of almonds, a pretty substantial meal, and you can avoid the nausea. One reason I say morning is because the closer to bedtime, the higher the risk of trouble with sleep and vivid dreams, very memorable dreams. I tell people that when I say that their dreams change, it's not that they're going to have nightmares necessarily, but the dreams get very vivid and very memorable, and you wake up in the morning not sure if that was a memory or a dream, because it was so real. And people tell me things like, I had a dream last night, I was flying through the sky on a dragon and it was all these colors, and I woke up and I couldn't believe it wasn't real the next morning. It was really cool. Other people have a dream like that and they're like, I don't want to know what happens at night. I don't want to remember my dreams. I want to wake up refreshed and ready to start the day. And so, I recommend, just take it, don't take it within 12 hours of bedtime, particularly for the first 3 weeks. Take it in the morning with a full meal. And that's one way to really reduce the incidence of these first two side effects. And then 5% will get a psychiatric syndrome. Part of this is fueled by nicotine withdrawal itself, but just feeling moody and impulsive. And so this is part of the reason that varenicline developed a boxed warning, is there was a percentage of people being prescribed this medication and were developing suicidal thoughts and suicidal behavior. And so the Eagles trial really turned things around. A huge study that really demonstrated that there wasn't a statistically significant difference between placebo and varenicline when it came to psychiatric adverse events. And it also really demonstrated how effective varenicline is. As you see here, compared to patch and bupropion, the abstinence rates, at 6 months, much higher. So at that point, the boxed warning was removed in 2016, and Chantix lived happily ever after. Okay, we know that's not true. In 2020, it was detected that Chantix, the way it was being manufactured by the former manufacturer, was producing as a byproduct a higher than acceptable level of nitrosamines. And nitrosamines are in just about everything commercially produced, and we're exposed to it in low levels in all kinds of, particularly processed foods. But a lot of times in the manufacture of medications, these lead to levels that are associated with a higher risk of cancers. And so at that point in 2020, the manufacturer halted production. I believe it was a voluntary recall. And as of 2021, it's a generic and new manufacturer, and there's been no issue with the nitrosamines. Okay, all right. Oops. Alrighty. So this is the top tier here represent our standard of care. And so varenicline and combination patch with either gum or lozenge tend to be our top tier, and this is how we meet the standard of care. It's by considering one of these two when we see a patient. It's all, the ones that are under 20%, nicotine patch by itself, nicotine gum by itself. You can see here that the combination really boosts the impact in terms of achieving abstinence. And so I'll have clients come to me and they say, I have tried everything. I have tried the patch, I have tried the gum, I've tried varenicline, I've tried that Wellbutrin stuff. I have tried everything. And I'll usually tell them, okay, and so have you combined any of them before? And they'll say, I could combine them. I say, absolutely. Combinations is where we really see even more of a success rate. And so I really like to call varenicline and patch my 1-2 punch, because the patch is great at addressing that first concern of staying at a nicotine withdrawal, and then the varenicline is great at staying one step ahead of cues and urges and triggers. But overall, what we practice in our program is adaptive treatment, meaning that I meet with a client, I assess their smoking history and their goals, and we together we collaborate on a first step plan. Then we follow up closely, 3 to 4 weeks, and we check in and see where they are with their cigarettes per day and how the plan is going. And then we come up with a new idea and then follow up again. And so that consistent follow up, meeting clients where they're at every appointment, and doing a good job of anticipating challenges between now and the next appointment is how we adapt treatment. And again, take the science and make sure that we can put it to optimal use for each client. Some highlights of what I do as a tobacco treatment specialist is, I don't come as hot and heavy with all the medication necessarily. So, perhaps using lower dose varenicline than what a PCP would do, low dose bupropion. I might do a 4-week, trial with a patch before adding in something like varenicline or bupropion. I offer extended treatment, maybe 3 months didn't cut it, 6 months didn't cut it. We can go for 12 months. I'll follow you long term. And then also using PRNs or add-ons like clonidine to help. What about e-cigarettes? What about not e-cigarettes? No, I'm just kidding. So e-cigarettes is a whole other bag of worms, but I just kind of wanted to talk about how it fits into what I do every day. So this meta-analysis showed that there is, in fact, some validity to the idea that people can stop smoking using e-cigarettes. And in our clinic, I have to say, we help thousands of people a year reduce and prepare for a quit. And probably less than 1% of those do we ever recommend e-cigarettes. And, what we say is nothing belongs in your lungs except for fresh, clean air. And we don't know the long-term impact. We don't have the longitudinal studies to recommend this the way we can with the other medications. So, and then of course, insurance doesn't cover it anyway, and there's other factors. But we don't often recommend this, but it shows that there is effectiveness to, if your goal is to stop smoking cigarettes, but not stop nicotine and not necessarily protect your lungs from scarring, so that this could be an option. And this next table kind of illustrates that, in studies, 80% of people trying to quit will continue using the vape. So, and then 20% of those become what we call dual users. So they're just as, dependent on the vape as they are on the cigarettes. And so now, and thinking that they were going to stop smoking cigarettes and start vaping, now they're vaping around the clock, and they're also smoking. And so they come to me. I see just a proportionate number of dual users, because a lot of people who vape don't really feel that they have a problem, and so they don't really seek treatment. But people who are in this 20% where now they are stuck with a dependence on two of these, a lot of people come and say, I can't afford to keep doing this also financially. And so we tend to set 2 quit dates. So we kind of determine the pattern, the relationship with each, each dependence. How are they using the vape? How are they using the cigarettes? Which one do they have a higher affinity for at that time? And we will phase in 2 separate quit dates. Quit the one that seems easier to quit, and use that momentum to quit the second one, usually within a month of the first one. And then this is a good comparison to have. 9% of people using the patch have a trouble going off of it and using it long term, but 80% of people who vape in order to stop smoking continue to vape. And once they're vaping, it's sort of like smoking in a boundless way. Smoking in the house, at work, in the car, in front of people. It really changes the behavior, and it's just a very different relationship with nicotine. Their ability to ride the wave and delay until a break is sort of obliterated for many of them. So I love being able to help dual users quit both of them. And so I'd like to kind of go over the structure of a typical visit, and again, how I put the science to work for my clients. I start with some rapport building. We go over motivation and goals and sort of assess confidence level. We talk about challenges with prior quit attempts, and we go over the plan, what medications might work, how we can enhance things with therapy, and anticipating challenges, and plenty of follow-up. So rapport building is critical. I tell people we are putting together a team today. And so this is when I get to know the client. It's so easy to find something that I admire. I get to see a lot of my clients, about 75% of them, virtually now. So I'm not just meeting the client, I'm meeting their kittens and their dogs. I'm seeing their artwork, and I'm always finding a way to connect from that first meeting. I love being able to adopt a proactively non-judgmental approach. When I'm assessing for a support system, I ask people, so who in your life is supportive of you quitting? And a lot of times I say, well, everybody's telling me to quit. And it's like, well, are they cheerleading for you to quit and cheering you on? It kind of feel like they're nagging you. And a lot of people feel like they're in a situation, they're being judged, they're being nagged. Everybody around them has already quit smoking. They're the last holdout. And so I love being able to create a space where, there's no judgment. There's nothing but encouragement, and there's going to be good days and bad days. And I let clients know, I'd love to know about your triumphs. I'd love to know about the good days. And I'd also love to know about the bad days also, because I'd love to keep the conversation going. And of course, demonstrating empathy is really, really important to keeping that alliance going. So I love knowing about the patient's personal motivation and goals. A lot of them will say, well, my cardiologist referred me, my cardiologist wants me to stop, my endocrinologist told me I need to stop. And I really love to turn the focus on, so tell me why you would like to quit smoking, because I'm here for you. And so a lot of times it's not necessarily the whole health goals. There's other reasons they want to quit. They want to quit because it's almost $10 a pack right now. I can't quit smoking. I can't keep up with this. I can't afford this anymore. Other people, I've had several recently who are looking at assisted living facilities, and they're realizing that the smoke-free facilities are way nicer than the ones that allow smoking. And I'm like, if I'm going to get into this facility and make this work, I need to stop smoking because I want a better life. And then other people again have various health goals. A lot of people are say, I want to be there for my grandkids, and I don't know if I can make that promise to them that I'm going to see them walk across the stage at high school graduation if I continue smoking like this. So there's all kinds of great reasons to quit. I'd love to know more about that, the meaning behind it for each individual patient. And then I love setting goals with immediate impact. Again, we're not doing cold turkey, so we're talking about, just incremental goals toward 0 cigarettes per day. And a lot of things that I do in terms of, immediate goals is let's create some smoke-free zones. I love finding out where a person is smoking, where their smoking sort of areas are throughout the home and throughout their lives. So, if you're smoking in the living room, bedroom, and the car, which one of these can we create where we can create a smoke-free zone? And so a lot of times they'll pick the bedroom first, they'll clean it out, get all the smoke out, no smoking materials in there, and this is a smoke-free zone. And and they tend to be very protective of that zone. I'm not smoking there, nobody's allowed to smoke in there. And then next time we move into the living room and create a smoke-free zone there. But oftentimes, even if they weren't able to necessarily, decrease their cigarettes per day very much in between appointments, we are able to celebrate the fact that there is one less place in the house that they're smoking. And so just finding those goals. Another popular goal that we have is delaying the first cigarette. The first cigarette might be within 5 minutes, but now that we're on nicotine replacement, let's see if we can make that first cigarette for the day 30 minutes after you wake up, an hour after you wake up, an hour and a half after you wake up. So those are some of the incremental goals. And again, we're not just ripping it off like a Band-Aid. So it's all about this, celebrating those milestones and those victories along the way, and adjust to their pace and their own personal goals. Some people come to me and they're not really interested in quitting. They're interested in reducing. I'm spending $200 a month on cigarettes. I'd like it to be $100 a month. What can you do for me? And, sometimes once we get to $100 worth of cigarettes a month, whatever that looks like for them, they're like, okay, I think I want to quit now. I feel like I got the momentum. I'm going to go for it. So this is the highlight of what I do. Patient challenges. This can be a bit emotional here and stressful. So sort of reliving past attempts, successes, and the things that didn't go as well. And so we talk about, how did the withdrawal symptoms impact things? What urges and triggers did they notice? How stress might have brought them back to smoking, or depression or anxiety, or how, again, weight gain can drive people back to smoking. A lack of social support. Sometimes a couple decides they're both going to quit, and one person does and the other doesn't, and then you've got somebody who returns to smoking pretty quickly. So it's always good to have that in our assessment. Motivational interviewing is the tool that I use, and I'm sure many of you are very expert in, and it's all about opening up the discussion with open-ended questions, allowing the clients to sort of tell their story, find some of their own solutions as well. It's about affirmation and reflecting so that a patient feels seen, and summarizing things also. So again, it's all about active listening, discovering that motivation, and it really helps fuel a quit attempt. Mindfulness is one of our non-medication approaches. A lot of smoking occurs automatically. Before I even realized it, I was smoking. I was lit up and I was smoking again. And so mindfulness is about being in the moment, being aware of why you're smoking in this moment, and just again, not judging it at all, it's all about just being aware of the trigger. And when it comes to judgment, another highlight of what I do as a tobacco treatment specialist is we talk about the value in smoking. You haven't been doing this since you were 16 years old because it didn't bring any value. So it's all about also valuing the behavior that you're ready to move on from. So mindful smoking, and a lot of my clients love to practice mindful smoking. It's about creating a space where you can smoke and really be aware of what's going on in your body. You're paying attention to the feeling of it, how your breathing, or how your body feels, focusing on all the physical sensations that come with smoking. And during this time, we want no self-judgment, just realizing that you're giving something up, and that I like to tell people that when you're enjoying this mindful smoking, keep in mind that these might be some of your last cigarettes ever, because I think that we're going to make this happen this time. And then I love to introduce the 4Ds. And so this is how we approach a quit and start practicing the skills that it takes to prevent a return to smoking. So delaying smoking, distraction, finding other things to do with your mind, your hands, deep breathing is a great way to avoid smoking. And then drinking water. I have several clients who, have determined, before I pick up a cigarette, I have to drink an entire glass of ice water. And a lot of times, by the time they've made it through that glass of ice water, they've totally forgotten that they were planning to smoke. So, and I just wanted to share with you some of our upcoming trainings. We've got our full form virtual TTS trainings coming up. Really happy about these. In March, July, and November, we've got our intensive one-day treatment trainings and various topics. And then we also have our toolkit, which is a great resource. We have a free CE activity, and we have our tips blog. And I might be one of the people writing for that blog soon. And so these are all ways that you can get involved. And so thank you for listening in.
Thank you so much, Marlena. Really enjoyed, all your personal stories with your clients. I think it's really touching and, kind of different from what, our other speakers have been able to share. So kind of having that personal touch and, your knowledge, your experience is really great. And I know for some people it might kind of been overwhelming to hear about all the different medications, NRT, but no worries, we're not all TTSs like you. I think it's just great that you were able to point out all the different types of medications, because I know my friends who try to quit, they'll think like, oh, only cold turkey. And you talked about, what one of 5 people who of 100 were able to like successfully stay quit after 6 months. So I think it's good to know all the different medications there are and the different combinations, and it works. One thing may work for someone and not work for someone else. But I think that's great to know. And I know there are some questions in the Q&A. I was able to answer some of them, but if not, we'll send the PowerPoint out as well. And I have written down the questions, so I can ask Marlena to ask. You can answer them off camera, and we can send that in the follow-up. That's okay. Okay,
That'd be wonderful.
Perfect.
Yes.
So I'll pass this on to Gina to kind of wrap us all up.
Thank you so much, Marlena. Oh my goodness, that was a wealth of information. I learned a lot, and I know everyone on the webinar did as well. I had lots of takeaways, so I'm not going to go through them all, but my one big takeaway is you really come up with a very thorough, complete, individualized plan for each tobacco user as they start their journey. And you really take into account everything, and you work with them, and you're non-judgmental. And I think your approach is phenomenal and amazing. And I hope that everyone does take time to kind of keep that PowerPoint, go back to it when needed. And Marlena also mentioned some tobacco treatment specialist trainings throughout the year of 2023. And we, with the Virginia Department of Health's Tobacco Control Program, coming up, and you'll hear more about this, but we're hoping to be able to train at least 38 tobacco treatment specialists throughout Virginia. So Rita Miller, who's our everything cessation, the cessation coordinator, will be sending some information on those trainings out to everyone as we get more information about them. So stay tuned. And also, please join us for our next webinar. It's Tuesday, February 28th. We're going to be hearing from the American Lung Association's Thomas Carr and Alex Casper, and they will present on Virginia's 2023 Tobacco Control Report Card. So we'll see where we stack up with our report card and how we can hopefully improve. Please note that this is the 4th Tuesday, not the 3rd, but please share with your colleagues, join us as well. Again, a fabulous webinar. We're so thankful that all of you were able to join us as you start 2023 and we continue on. Just make every day impactful with how you treat people and go about your work, because I think that really does make a difference. And I know it makes a difference to our team, your support and your commitment. So thank you all and have a wonderful day.